Good evening and welcome to this evening's meeting of the Health Scrutiny Committee. On the call tonight we have Councillors Carter, King, Marks, Wheeler and Williams. Also on the call we have officers from Warrington Borough Council and colleagues from health partnerships across the borough. This evening we've received apologies from both the Chair and the Deputy Chair. So it's been proposed that Councillor Williams chairs for the meeting. Am I able to get a proposer and a seconder for that?
Yes, could I propose that Councillor Williams is the chair for the evening?
Yeah, and Councillor Wheeler, Councillor Wheeler, I'll second that.
Okay, thanks, Councillor Wheeler. I take that's the will of the meeting that Councillor Williams is appointed as chair for this evening.
Yes.
Yeah.
Okay, yeah. Thanks very much. Over to you, Councillor Williams.
Thanks, Adam. Welcome to members and officers for the November meeting of the Health Overview and Scrutiny Committee. Do we have any other apologies?
It's Lucy Gardner from Warrington and Holton Hospitals. Please may I offer Simon Constable, the Chief Exec from Warrington and Holton Hospitals, apologies, and I'm here on his behalf.
Thanks for that.
And it's Sarah Quinn. I'm here on behalf of Colin Scales. Can I offer his apologies as well?
Hello, it's Lorna Pink from North West Boroughs. I'm here on behalf of the Trust. Normally Mike Kenny attends, but unfortunately he's unable to this week.
And additionally, Chair, Councillor Hall has sent her apologies as well.
Thanks for that. Code of conduct, any declarations, members?
Chair, yes, from me. Councillor Wheeler, I am employed by Mercy Care, so should any discussions come up about the proposed merger with North West Boroughs, I would have to declare an interest as an employee of Mercy Care. Thank you.
Thanks for that, Councillor Wheeler. Can we confirm the minutes of the last meeting? Anyone with any questions? No? No. I'll take that as read that we confirm the minutes then.
Yeah.
Move on to item 4, Warrington Together update. Simon, please.
Thank you, Chair. I'll be brief. The work that was progressing in relation to integrated community teams has been put on ice because the staff of Warrington Together have been deployed at the hospital in terms of discharge just to help out the system. So as I say, that's been put on ice, but we have been visible in other forums. So we had a very good presentation last week at Disability Awareness Day. We had a session around frailty and we explained to 30 members of the public the work we're doing in relation to frailty. And that's not just frail elderly, that's frailty of any age. Also last week, I'm sure members are aware, and I'm sure Lucy will inform you more, but we were successful in getting £22.5 million for the new town deal. Components of that bid include some elements of health, including a wellbeing centre in the centre of town. Today, there's an organisation in Warrington called Movement, and they're holding an anti-suicide event, which colleagues are attending. But that particular organisation, Movement, is becoming more prominent as a partner. And finally, we had a very successful meeting with Taurus to discuss the possibilities of developing a pipeline of bids for the Homes England Fund. I'm happy to take any questions, Chair.
Thanks, Simon. Members, any questions? No.
Chair, sorry, I've lost my hand function somewhere on my screen. I'll have to try and find it. Just a couple of questions, if I may, Chair.
Go ahead.
Yeah, the town centre fund. How does that sort of tie in with a town centre hub? How does that tie in with the Bath Street offer at the moment? does it enhance it or?
Well, yes, there are a number of
alongside it?
town centre hubs, aren't there? We're using Wolford Jubilee Hub. Yes, I mean, Lucy and I are discussing the possibility of that being an outlet for the voluntary sector potentially. So it will enhance the offer in the town centre, together with the other bids, parts of the bid, cycling. So cycle hub at the central station.
Right, so you're not talking about an actual location?
Yeah, we're doing some work around, we have an asset registry across the public sector, so we are looking at potentially a geographical location. But I think we discussed this last week in terms of access to health isn't an issue in the town centre. So that's why we want to think about something more holistic in relation to wider determinants of health. But that's to be determined, Councillor Wheeler.
Oh, okay, thank you. And just also a little bit more about the Homes England funding.
Yeah, there are,
and what that would involve.
So Taurus is a strategic partner for Homes England, so they get a slew of money on a regular basis. And Homes England have produced quite a helpful documentation around what sort of bids that they will be looking at. So we're looking with the hospital at potentially relocating the 29 people with learning disabilities we've got outside the borough into accommodation, but also we're intrigued around the opportunity for young onset dementia, but we're working with Taurus and commissioners at the council and the hospital to look at that. But potentially that's a step on really from where we are in relation to housing and relations with housing.
Thank you.
Okay, any others? Any more questions? No, I just have one, Simon.
Yep.
Do you have any specific projects in mind, or is it just a general discussion?
For housing?
Yeah, yeah.
Well, we're looking, as I say, at the 29 individuals who are placed outside the borough in quite expensive locations. So it's about rehousing those within the borough. And I'm talking to the hospital about what's the need for young onset dementia. So we're shaping those at the moment, but there are 17 different categories of potential bids, which Homes England have just released in September.
I see.
I hope that's helpful.
Right, thanks. I'm just thinking specifically of the possibility of a dementia-friendly establishments on Omega. There's a planning application gone in for people who are interested in building something on Omega. I just wondered, has that been in your discussions?
It was, because tourists have a similar development to that in St Helens, which they've just taken on. So I'm going to try and arrange a visit. So if you'd like to accompany me and the portfolio holders, we can do that, Tony.
That'd be very helpful, Simon. Thanks very much.
Okay.
Okay. No one else? Okay, thanks for that, Simon. We move on to public health and Thara.
Thank you. I'll just increase my volume.
Sorry, I think you've just muted yourself or volume off.
Oh gosh, my connectivity I think is going a bit funny. Can you hear me?
Yes, we've got you back now.
Thank you. Have you? Okay. Apologies. If you can't hear me, Adam, I'm going to email you the slides, and I will you know, I'll answer any questions afterwards if you lose me. Is that all right, Chair?
Yes, that's fine, Thara. Yeah, we can.
Yeah.
Okay.
Yeah. So I'm just going to try and share my screen. If I can. Are you sure you want to share? Yes. And I think that's it. Could you tell me if you can see that, please, Chair?
Yes, that's coming across clear. Yes.
Okay, I'm Tara Raj, I'm Director of Public Health for Warrington. You'll have seen a rough, these slides, a few weeks ago. But what we do as a team is update them so you have as close to possible the situation report for councillors and communities. I'm going to give you a very quick overview. You probably don't need me to give you an overview because you've all have seen the rates going up. However, I will do. I'll give you an overview of the outbreak management work and also a little bit about, sorry, I just skipped by accident. A little bit about, what additional stuff is put in place. Yeah. So, surveillance trends. In the week leading up to national lockdown, we had a rate. Now, you're probably wondering which rate you should work with. You'll have seen that Russ, our leader, has been making sure that the right rate is on our website, the one to watch. So we're using the 7-day infection rate. And for Warrington, in the lead up to lockdown that week, we were at over 420 per 100,000. I've put the precise figure in there. That meant that there were 892 new cases diagnosed in that week, just in Warrington. In terms of positivity, it was 13%. Now, anything, national teams say anything above 5%, you should be worried about. And we had 78 new COVID admissions to the hospital, the local hospital, over that period. You can see on the right, it's maroon, and a bit like the last presentation I showed you, maroon is not good. I'll just pause on that because people always like to see their wards. They like to see the current picture, but that's been updated, so I'm not going to dwell too much on that one. I'm going to move to the next one. Okay, so the latest position. So if you think back to just before lockdown, it's 424 per 100,000. It's slipped. Someone else has started sharing. Could somebody else stop sharing, please? Am I back? Yeah, great. It's 932 new diagnosed cases, and our rate is 443 per 100,000. So going into lockdown, we are worse. So unlike other areas in the Liverpool City region, you'll have been hearing that rates are going down. Unfortunately, they have not been going down in Warrington. They have been going up. So unfortunately, Warrington is the highest in the Cheshire and Merseyside region, and we are ranked 20th in England. Our positivity has gone up from 13% to 14%, and we have had 94 new COVID admissions in that week. Okay, so and obviously the data is increased because this is now over a day old. So we're seeing increasing numbers of deaths, and unfortunately colleagues in the hospital who are on this call will be seeing that firsthand, and we are grieving. If we look at the spread by age, so I'll just talk you through the colour coding. Black is not good. Yellow is good. There isn't yellow on that picture. Unless you're telling me that there's yellow, I can't see any yellow on that picture. It's amber, 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 red, black. So on every age group, apart from the 0 to 15-year-olds, we're seeing, we're seeing blacks, and a 60 plus, we're seeing nearly blacks there. We're seeing purples, which is not good. So as we're seeing across the country, it's the 16 to 29-year-olds that have the highest numbers of rates of cases. However, as you can see, the 60 plus are absolutely creeping up, and unfortunately, quite a few of our communities are suffering. The black line is England. The northwest line is yellow. If you suffer from colour blindness, the black line is the one at the bottom. The northwest line is sort of the one that's close to the purple one, which is the top two ones. If you can see, Warrington, which is the purple line, exceeds the England line and it exceeds the northwest line. If we look at the data around pillars, pillar 2 testing, pillar 1 testing, you can see that testing has increased. I don't want to dwell too much on that because I'm going to return to this. You can see the hospital admissions being higher than when we were at the peak in March, April. As I said, I'm going to dwell a bit more on the testing and positivity trends shortly, but I don't want to run out of time. If you look across the Cheshire and Merseyside, as I said, rates seem to be coming down across the Liverpool City region. The narrative seems to be that the level 3, very high risk areas that went into that category before us seem to be coming down. I think Cheshire, you know, we're higher than everywhere else. It's gone down except for in Cheshire West and Chester, but it's not gone up by very much. What are we doing about it? Around the education setting, so many of you will know Paula Worthington and Louise Atkin, who work at the Council on Education. They've been leading a schools task force with our head teachers and others, including early years colleagues and FE colleges. And what we're seeing is a not great picture across the education sector. So we've had over 700 cases reported since September. 86% of settings have reported cases since September. You know, I can read all of the detail, but I'll also send you these slides, colleagues, if that's helpful, so that you can peruse them at your leisure. If you look at where the, you know, if you can spot where there's no outbreaks, please let me know, because basically, you know, every setting has had at least, you know, one lot of more than 2 cases of COVID. The good news is that no schools are currently closed. If we look at our business sector, we have worked extremely hard as a council. So our environmental health team and our public health local outbreak office have supported over 200 businesses to be COVID secure since mid-August. We've managed and closed 100 outbreak cases, not just with us, but with other colleagues as well, and other partners. We've managed outbreaks in over 20 premises, 27 to be precise. Where we're seeing the most numbers of cases is distribution centres, call centres and supermarkets. That isn't to say that they're not safe. Trying to be overheard with the fireworks, tricky, isn't it? The high local community transmission often spills over into those settings. I've got a couple of minutes left. So in general, most businesses are doing the right thing, and we're going to be renewing some sector-specific guidance as we ease out of lockdown. If we look to the care sector and the complex settings sector, we've done a lot of work. Our adult social care team have worked with our local public health outbreak office and the NHS Community Infection Control Service that Bridgewater is housed in Bridgewater, and we are working with care homes and that sector around COVID security. And there are clear outbreak management plans in place for each care provider. Whole care home testing, which you'll have heard a lot about, it's continuing. We have produced some very helpful risk assessment tools with our care providers to facilitate visiting policy. You'll have heard a lot about how difficult it is for people to visit their loved ones. And unfortunately, cases amongst our local travellers community rose, but were successfully managed with good engagement from all partners. Testing and tracing. People wonder, is it because we're just testing more? And yes, partly it is that, but also the positivity shows that we are testing the right people. So there is quite a lot of transmission and cases out there. So yes, our testing rates are slightly higher than the rest of Cheshire and Merseyside. We are seeing increases in testing rates, whereas some of the local authorities have seen a reduction. Our testing site at Academy Way is operational 8 AM to 8 PM, 7 days a week. And we are keen to increase opportunities to have more sites available. There is, in addition, the mobile testing unit that comes and situates itself in Orford Jubilee. And we also have, if you have a car, we can get to Haydock and Runcorn. It seems to be that people who want to be tested are being tested and are being offered testing. So the capacity issues that we were experiencing seem to be removed. However, we are trying to look at new testing technologies. If we look at our contact tracing, over 80% of Warrington residents have been in contact with our test and trace system, which is very similar to the England figures. Sorry, 80% of Warrington residents with COVID, not 80% of residents. And you can see the figures in terms of successfulness in the NHS test and trace system. So I won't go line by line on each of those, but I'll just give you a moment to reflect on that. So what's happened is that the loss to follow-up cases have been being referred to Warrington Borough Council, to the local public health outbreak office, and they're being followed up. This is a little bit more information about those loss to follow-ups that the NHS test and trace system couldn't reach. And when you see the slides, you can peruse them and then see that of those that were referred to us, we managed to contact over 40% of those cases. And when we did, they all said that they'd been self-isolating. So, you know, it is spreading quickly in Warrington. It has been since the end of August, early September. It's particularly, it was in the younger age groups, but now it's spreading to older age groups as well. We are seeing quite a lot of transmission, which is leading to more serious complications, ending up in hospital admissions. Every sector is affected. There are schools, a number of schools who've been affected and keep being affected, businesses as well. They're being really COVID secure, but we have such high levels of community transmission that it's hard to keep it out of our settings. Hospitality has been a particular issue, and wherever there's been a complaint, it's been dealt with and investigated. So lockdown will provide a little bit of space to work, do some more preventative work with our colleagues in all settings. So just to round off, in terms of the actions and the next steps, we continue to have regular meetings with government departments, not just the Joint Biosecurity Centre, with Cabinet Office, with Number 10, with MHCLG, and we continue to share the Director of Public Health narrative report with them. We've got an action plan and comms strategy in place. we've got, you know, lots and lots of communications going on that's targeted. The tier 3 restrictions that that came out at the same time as the national lockdown restrictions means that when national lockdown eases, we're likely to be left with the higher level tier 3 restrictions, which will be news to a lot of people. So we need to work very quickly with our communities to help them to understand that. So we're trying to expand our local contact tracing service, and we are working very well across the Cheshire area as well as the Cheshire and Merseyside area to have consistency. I think that's where I just wanted to stop, but I really wanted to say a big thank you to not just the people mentioned here who helped produce the presentation, but all colleagues across Warrington Borough Council, as well as the hospital, the CCG, councillors who put in those tireless hours, and other colleagues. Thank you.
Thanks, Tara. Any questions, members? No questions? Thanks, Tara, for that.
Thank you. And I'm going to say goodbye now. Thank you.
Okay, thanks for that. Bye. Okay, go to item 6, Warrington Hospital update. Is that Lucy? Hello?
Chair, we should still have Lucy on the call. I'm not sure if she's still muted.
One more call. Warrington Hospital, Lucy, are you there?
Okay, Chair, we can move on to the next item and then come back if Lucy rejoins the call.
Yeah, I'll just keep an eye on that one. Okay, move on to item 7. It's the Adult ADH Services report from Warrington CCG. Andy, I think.
That's me. Thank you, Chair. Hopefully, can you hear me?
Yes.
Perfect. Yeah, there's a report in the pack for you, and I'm not going to go through it too slavishly. Ultimately, this is about adults with ADHD or those transitioning from paediatric services into adult services with the diagnosis of ADHD and their ongoing assessment, care and treatment needs. It's a challenging service to deliver for any provider, and obviously is a growing service. Absolute numbers remain fairly small, sort of in the few hundreds, but a significant impact on the lives of those that need the service. And this one's been an ongoing wrestle with us for the past couple of years. So oh, sorry, I'm getting some feedback. I think somebody's come off mute there. Is that, there we go, that's better, thank you. So we had some local issues with North West boroughs that we were working through with performance notices, and CQC visit had highlighted some concerns as well. And there was a point, I think March the year before, where North West boroughs decided that they would need to hand back the contract because they weren't able to deliver. We'd evaluated other services at the time, so Merseycare and CWP, but both of those services were quite stretched with very long waits, and in a lot of cases these were getting up towards 2 years, which is not really a viable service offer for those people that need it. There was a guidance issued nationally about how to help these people, and the recommendations were around integrated services that were offered in community with consultant oversight, medication being prescribed by GPs, and that was the model that was worked up at the time, which we are ready to get going with. We were due to start earlier in the year, with a process of consultation, engagement, and getting that rolled out. But obviously, with the events due to the global pandemic, that kind of stalled things for us. So in the appendices and the background papers, it goes through the processes that will be undertaken through engagement over the next few months whilst we are trialling this new way of working. It's a 12-month run through and see how we do, and it should significantly reduce those waiting. And I think we've captured some numbers in the covering paper for you there of the adults that are currently on the waiting list. There's 188 for Warrington that are still waiting, and the 63 young people who are receiving ADHD treatment in Bridgewater, they're due to transition. And Bridgewater have been helpful in sort of extending the age that they'll continue to supervise those patients whilst we're getting this up and running. So I will leave it there, Chair. I'm happy to take questions. I also have a colleague with me, Margie Butler, who is the Mental Health Commissioner, who's been leading on this with the clinical leads. In case there's any detail that foxes me, she'll be my phone a friend.
Thanks, Andy. Members, questions?
Chairman, can you hear me? It's Ian Marks.
Hello, Ian.
Hi, yes. Yeah, no, thanks for that, Andy. Just a really little bit about the patient journey. And in particular, I mean, there's this reference to shared care. If you could just say a little bit more about how that would work. And in particular, I mean, if there needs to be a change of drugs by GPs, how that ties in with that. Thanks.
So with good questions, Ian. So shared care, the drugs that are usually used for ADHD are controlled drugs, and they're often on a list of medicines which are for consultant supervised prescription. So they can't be prescribed in primary care. And what that then means is that the consultant would initiate a prescription, stabilise treatment, and then hand over the prescribing to the GP with regular monitoring through the service that will be commissioned to make sure that the medication is effective, still being used within the current guidance, because that changes sometimes, and also that there aren't any emerging side effects or problems that are being generated by the medicines. We wouldn't be expecting GPs to necessarily make changes to the prescription other than within a pre-arranged schedule, if that was agreed, that there could be some dose adjustments based on guidance. But most usually with shared care arrangements, the medications are fixed, and if there was a need to change, there'd be a further review by the consultant or supervising specialist clinician to make the recommendations about change.
Happy, Ian? Ian?
Yes, thank you.
Okay, I've got Jean next.
Thanks. Andy, thanks for this. It's obviously a big improvement to what we've got at the moment, because the treatment that ADHD were getting was practically nil. But can I just ask a couple of questions? Where are the consultant psychiatrist and the nurse based?
That is a good question, and I might have to ask Margie that one.
Okay.
So she might type it in chat if she can't speak. So it'll probably pop up for me.
Hi, I've just joined the call. Can people hear me? It's Margie Butler.
Yeah.
Yes, hello, thank you. I've just picked up the question about where the consultant's based. So the consultant psychiatrist who will be overseeing the service, she's Dr. Helen Reid. She's got a 30-year NHS career. She is physically based in London, and the nurse consultant, Jonathan Lanham Cook, he is physically based in Bristol. They'll be virtually offering this service, very similar to so many virtual services we're offering at the moment, but there will be a physical base for patients who can't or don't want to engage virtually with the consultants at Bath Street.
Okay, so that leads me to another question, if that's okay, Chair. So who will do the assessment at Bath Street?
What will happen at Bath Street is that if people don't have access to technology, they can be supported in using technology at Bath Street. And they will be supported by healthcare assistants who will be employed to be part of the overall ADHD service model, and they will be supporting with physical health checks as well.
Okay, so the actual that will be from video from Bath Street with the consultant and the consultant nurse.
Yeah. So it will be an online assessment, and as I say, the ability to go into Bath Street as a physical location with healthcare assistants to support that online assessment and discussion if necessary.
Okay, so again, Chair, if you'll allow me to ask another question. So when the diagnosis is made, how many appointments then will be for each patient, or will they be immediately sent across to their GP?
Oh, crumbs, I'm not quite sure I followed the question. Can you repeat it, please?
Yeah, sure. So say the diagnosis is made at Bath Street with help from healthcare assistants, with the psychiatrist or consultant nurse, and then when will this patient be seen again? Will that go across to the GP to
okay. Apologies, now I understand. So it will be the consultant psychiatrist who makes the diagnosis of ADHD or not, and that will be either, you know, from the comfort of somebody's own home if they have got access to internet facilities. If not, you go into Bath Street where you are supported to engage with the consultant online, and there will be, and there are accredited assessment tools, diagnostic tools, so that it will be possibly an hour online assessment, diagnosis made, and then it will be needs led. So there'll be a number of follow-up appointments made, and when the person is clinically stable on the medication that's prescribed for them, they will ultimately be transferred back to primary care to their own GPs under this shared care arrangement that Dr. Davis has described.
Okay, that's reassuring. Thanks for that.
Thank you.
So, and I think if in the pack, it's on page 19, the proposed new patient journey sort of touches on some of those with a little less detail, but perhaps helps with the ordering of things, which will help.
Sure.
Okay.
Thanks. Yeah, thanks.
Judith, you were, excuse me. Is that you, Judith? You want to come in?
Yes, sorry, Chair. Yeah. A couple of questions then, thank you for that. As well as the medication that will be that may be offered, are there going to be any non-pharmacological interventions such as CBT tailored for the needs of these patients?
Thank you. Yeah, absolutely. So we've focused on the medication in there because that's the bit that's subject to the shared care arrangements. But obviously, if medication is not the appropriate remedy, then that won't be used. And there are a lot of people with ADHD who actually having a diagnosis and a management plan. That's the help that they need to get through life and move forward. It's not always the medication that's needed. However, there are a significant number that do. So we're focusing on that, but there will be a range of non-pharmacological interventions available, including CBT, via the usual services.
Thank you. Just a couple more questions, if I may. Do you think this approach will meet the demands of the Warrington patients? Because the CQC did raise concerns about waiting list times.
They did, and that was part of the need to get this done. So we scaled it to do two things. One is get through the waiting list in a timely fashion, and the other is to provide ongoing treatment at sufficient volumes to avoid the waiting list building up as well. So there is a bit of front-loaded additional time to do that. I don't know, Mark, have we agreed the trajectories for recovery yet, or are we waiting on the list transfer?
Sorry, I'm trying to mute and unmute here. So we've got our numbers. North West Boroughs have been massively supported as we plan the mobilisation and the closure of one service to go to another. We've got our nurse consultant starting the 9th of November, all being well, and he's then going to spend a little bit of time working up those mobilisation plans, working out fine-tuning the trajectories, doing supportive work with our GPs, raising awareness, and other colleagues as well, working out pathways into mental health services, into substance misuse services, and so on. What we believe is, because we're going to be offering an online service, it's probably going to be more efficient and effective, because right now the DNA rate for our current service, and it's no criticism of it, it's pretty high, you know, between 30 and 50%. So when you've got your online opportunities to engage with people and make appointments, we probably will be seeing more people than we currently are. And we've got our nurse consultant whole-time equivalent, so we do have some additional capacity in the system.
So I suppose when we've got those trajectories agreed by the nurse consultant, we can share them back with the committee, can't we, so that they're cited on the recovery plan?
Yes, sure.
Okay, thank you. And can I have one final question, Chair, if I may?
Yes.
What are the plans for the transition from child to adult services? How will that journey take place?
So that should be fairly smooth, and I think we do outline that in some of the documentation. So currently, Bridgewater would handle diagnosis and initial management and treatment of paediatric cases with ADHD, and then at adulthood there'd be a transition into the adult service, with usually a continuation of the prescription at first, and then just review as to whether that's still valid, as we've discussed before. So it should be relatively seamless and relatively easy to facilitate. I think the issue we've had is with the long waits in the current services. It's been difficult to avoid interruption in those prescriptions or and friction at the transition ages. So this should be a more frictionless experience for those young kids that turn into adults, as we all do.
Okay, thank you.
Okay. Anyone else?
Chair?
Yes.
Yeah, the outcome agreements, and there's various bullet points underneath, which I'm a little bit confused about because I don't quite see how they relate. So the key question is really, how are we going to monitor and measure sort of the outcome agreements?
So I'm just thinking about, so there's two things that we were just in. One was the discussing in there. One was the engagement process, and the other is the clinical outcomes. So for the outcomes of the consultation, they'll be reported through as we gain that input from the relevant stakeholders and partners that will contribute to an assessment of how the service is working. Within the adult ADHD service, because it's an ongoing condition, quite often there's a set of outcomes agreed with the individual early on in the assessment and treatment process. But basically, what is it that they would like to achieve, either via diagnosis or treatment? What are the problems that they have with their life that are attributable to the diagnosis that they're going through? And then that would be monitored by the service to make sure that the treatment was still delivering the benefits that were proposed at the beginning. So it's a bit more of a holistic approach rather than just saying take a pill and that's all you can do. It's a range of non-pharmacological and pharmacological interventions, but all targeted at saying what is it that the individual wants to achieve by doing that, because we can't take away an ADHD diagnosis, but what can be done is ensure that it doesn't interfere with life and livelihood.
Okay, so in fact you're saying, which I'm pleased to hear, that the service users are going to be sort of, well engaged in this, and they're going to be sort of consulted about how the service is done. Okay,
that does often determine how treatment proceeds, because obviously not everybody wants to take medication, and not all problems are amenable to medication.
Oh.
And so there's that agreement of what the goals are of therapy that right up front.
Okay, thanks, Andy.
Okay, Amanda, is that you want to come in?
Yes, thank you, Chair. Thank you, Andrew. I think part answered what I've got 2 questions, Chair, if that's okay.
Yes,
The
fine.
first one is about that future engagement with the Warrington Speak Up on the charity piece. How do you see that working? Because you're right to say there's quite a lot of children that with ADHD, it doesn't go away. The service and the connecting to both the children's services and the adult services. So you've got a piece of this targeted piece of engagement. Could you tell me a little bit more about, because it just says targeted piece of engagement, doesn't give us any more quantitative approach to how you're going to move, just explain what that means to me if you've got it already drafted out.
We have, I think there's some information in the pack around page 27 of your PDF, but Margie's keen to take that one. She just dropped me a message going, can I answer that one? So she's a bit excited about it.
I have seen something, but just if you just give you the opportunity to talk us through it a little bit more.
Yeah. No, perfect. Yeah, go Margie.
It's a great question. Can people hear me okay? I'm just conscious of...
Thanks, Margie.
Yes, thank you for the questions. Great question. What we've done, so Warrington Primary Care CIC, as you know, are going to be the provider of the service. And they have agreed to commission Speak Up to work with our patients who are currently open to services to really engage them with the mobilisation in terms of what's going to happen next and help us to work up this dashboard, because within your papers, it gives you a flavour of some of the things we're going to be measuring. And we just want to make sure by working with patients that we are measuring the right thing in terms of the key performance indicators and the outcomes. What do people want from services? So it's a two-pronged approach, really. Commissioning Speak Up to support those people who are going to receive the service, make sure we factor in what they want from it, and use them as part of the performance management process as well.
Thank you. That's a great answer. Thank you. The second part, Chair, if that's okay, was more about, I know this is adult ADHD. I get a lot of requests from, there's a lot of families, there's a lot of ADHD children within my ward particularly. I did just want to bring up, some of them feel they don't get as much support in the school, even though the child needs medication. And it's self-prescribed medication. They may have to go to the front desk each day to collect that medication, and some are as young as 5, 6, 7 years of age. And it does a lot of responsibility on the school to help support that. I suppose my question is, what help are we giving to the schools who have children with ADHD and or those that are in high school becoming young adults to sort of support that sort of engagement between the school, the CCG and the child? I suppose that sort of virtual, I know it's a bit of a long stretch because the school's got a whole different section of what they need to do, but the whole well-being of the individual, not just on medication, but their life journey, I suppose. And I'm getting a lot of requests for moving schools, and people think that might fix it. It doesn't really. And I'll give you an example. The reason I'm asking the question: one particular child, I forgot to go to reception for his medication, and then obviously, if you understand travel ADHD, that cause can occur an effect for the rest of the day and disruption to class from that particular child. Is it the child's responsibility to take the medication? Is it the school's responsibility to help them take it? Is it the parents? There's a whole dynamics of everyday life as well as taking the medication, and we build an especially in the speech. I suppose I looked at the Speak Up and thought, what can we do to help the family, the child, and everyone else in that child's life have a great experience and have as much as a progressive life as they can. It's a wider question. There's probably no straight answer to it, but I suppose, what are we doing to help schools with children stroke young adults with ADHD, especially when it comes to taking the medication on a daily basis? Sorry, it's a long-winded way of asking that question. Okay, silence.
I was on mute. I was speaking very eloquently, but on mute.
Thanks, Andy.
Sorry about that. So, yeah, I think it raises some really good issues, the points that you've raised. Obviously, this is about the adult part of the service, so not directly related to those issues, but at transition will be there. I think so. A bit of a halo effect of having this approach there'll be more skills, knowledge and training in primary care about how to help with ADHD, and that's not just useful for adults, it's useful for all ages, because part of the package is that training, connection and support. And we'll have some more local expertise on the patch as well, around management of ADHD, and more conversations going on, so that will help. We've got some work ongoing with neurodevelopmental pathways, and some of that will also help with children who have developmental needs and at school age, and that's well connected with schools, with other groups such as Warpack and other things that we're developing that and co-designing it. So that will also, I think, contribute to helping with that. Because the perennial issues about where does the responsibility for that medication sit when a child's in school, and ultimately you could say the teachers are acting in loco parentis, so it sits with them, but they're never comfortable accepting that and they can't administer the medicine. So it's it's a perennial that we do need a better solution for, because I've got daughters who are growing up now, but I wouldn't have trusted them to prompt to take medication at the age of 5. So I think that's something that, you know, rightly raised. This won't resolve it, but there are other things that will help, and it's something that we can take back and make sure is factored into thinking.
Thank you. That's all, Chair. Thank you very much.
Okie doke. Anyone else? I've just got a couple, Andy. Thinking back, will the acquisition of North West Boroughs by Merseycare impact on future service provision? For this service for adult ADHD? Yeah. No, because it's a separate offer. So because it's been commissioned as a wraparound with primary care support, it won't be affected by that move. Right. So are there any cost differences between the commissioning of North West Boroughs and then the commissioning from Warrington Primary Care, CIC? This is more cost effective. Right. So than the service offer that was proposed. And I mean, ultimately the contract was withdrawn, and then there was another offer that was proposed that was more for Halton and Knowsley, but Knowsley CCG wouldn't participate. But yeah, there's some cost efficiencies within this which allows us to do more around that, and obviously those would be reinvested as part of the mental health investment standard. I see. Okay, thanks for that. The issue of a possible conflict of interest was discussed at the CCG Commissioning Service Development Committee. Why was this discussion needed, and can this discussion be expanded? So obviously with the need to create an integrated service around general practice, we're a GP membership body, so any GPs that would be involved in it needed to be either excluded from the decision-making process or otherwise. So the records of how the options were appraised are there and available for scrutiny, but we were conscious that it was a change to service that was in line with national guidance. So the national recommendation was to have a primary care up service, as it were. So that decision was through there, and the Commissioning Service Development Committee does have GPs on there, so they were asked to leave if they had any pecuniary interests in it. I see. Okay, doke, thanks for that. Any more questions, members?
Chair, we should have Lucy back on the line if you wanted to go back to the previous item.
Okay, thanks for that. Lucy, are you there?
Hello, Chair. Can you hear me this time?
Yes, I can hear you.
Huge apologies. I couldn't unmute previously. So I'm just here on behalf of Simon Constable to provide an update on the COVID position from the hospital, which follows really well from Zara's presentation. So just an update really in terms of numbers and current positions. So currently we have 158 COVID positive patients in the hospital. That was 154 at noon today, so that is a live position. 18 of those patients are in critical care. And we also have an additional 10 non-COVID patients within critical care. And just for a bit of context, our normal critical care bed base is 18 patients. So we're actually 10 patients over in terms of that critical care normal capacity. Just also to put those numbers into context in terms of the previous peak in wave 1 back in April. So we've now exceeded the highest number of patients that we had during that peak, which was 124 on the 13th of April. So that 124 compared to our 158 today. We actually have the same number of patients then in critical care from a COVID perspective that we do today. Some other important context which I think is quite helpful and may give us a little element of hope for the future. Wednesday the 14th of October, we had 80 patients, 80 COVID positive patients in the trust, so that was 22 days ago. So we could say that it's kind of doubled in 22 days. Back in the first peak in wave 1, it was the number of COVID positive patients was doubling every 2 to 3 days. And at the beginning of this peak, it was doubling every 7 days. That then moved to every 14 days and is now at 21 days. We are continuing to plan for there being over 200 COVID positive patients within the hospital. And so far we've had 2,260 patients tested positive in terms of inpatients and A&E attendances. That's to date. Of those patients, we've discharged 646 patients who are COVID positive, and sadly we've had 201 deaths in the hospital. The remainder of those patients were not admitted, so that's kind of the difference, between the 2,260 and that 646 and 201. The week commencing the 19th of October, Vara alluded to this, we had 24 patients die of COVID, and that is one more than the worst week in our first peak back in April. So the worst week back then was the week commencing the 13th of April, where we had 23 patients die. Moving away slightly from COVID, our A&E ED attendances are relatively normal for this time of year, which is an additional challenge really, because when in the previous peak we saw quite a significant reduction in ED attendances. In terms of the hospital in general, it is safe and under control, albeit very pressured. We continue to provide a service for urgent and cancer fast track surgery at both Warrington and Holton, and a number of other services including endoscopy and diagnostics and ophthalmology. We also continue to use some independent sector capacity, particularly for planned surgical procedures, to avoid extended waits for those patients. And we continue to review the position daily. And it's just a quick update in terms of staff testing. So we've recently conducted a pilot around asymptomatic staff testing, and we've tested nearly 3,000 staff. And the rate of positive tests in terms of that group was 1.9%, which is actually less than the Northwest average of 2.9%. So again, a small element of positive news. And they're probably the key things that I wanted to highlight. Happy to take any questions or comments. Thank you.
Thanks for that. Members?
Chair, it's Councillor Wheeler.
Yes, Judith, go ahead.
Yeah. Thank you, Lucy. In terms of the high dependency and intensive care capacity, and you're still carrying out elective surgery, many cases of elective surgery, you have an automatic transmission after the operation, an automatic transfer after the operation to an HDU or an ITU bed. Given that you are at overcapacity, is this going to affect major elective surgery in the near future?
So we're continuing to review elective surgery on a daily basis, and there are elements of elective surgery that we have already paused. obviously not in terms of the urgent cases and cancer fast track. So it's really difficult to say at the moment. We've extended our critical care capacity, and some of the extension of that capacity is into operating theatres. So we have had to reduce elective surgery, but like I said, we're going to continue to review that on a daily basis, and that will determine whether we have to reduce that further. We are looking to additional capacity in terms of additional bed capacity to be able to prevent that reduction, further reduction in elective surgery.
Okay, thank you.
Okay, thanks for that. Anyone else, members? Any more questions? No. Okay, thanks, Lucy. Thanks for that.
Thank you very much.
Thank you. And we'll move on to item 8. Again, I think this is Andy, health provision for residents in Burton Wood.
There we go. Thank you, Chair. I was using the *6 there, and it tells you that you're unmuting, so you have to wait till she's spoken. This one's another long-standing issue with regards to healthcare provision for people who live in Burton Wood, just over the motorway. So the patients there, or the people that live there, are registered predominantly with 2 practices in St Helens, which means that they fall under the St Helens CCG auspices for certain elements of the care, including primary care, and they receive a full suite of community services and other care via Warrington CCG. So it's always been a bit of a problem for that ward. There's some work ongoing now with the primary care network, Warrington Innovation Network, which exists in the eastern north of the town. Western north of the town, and will cover Burton Wood, and a bit of a push on there with local councillors as well, to see if people want to choose to register with the practice. That's been resisted a little bit by the St Helens practice, who obviously want to keep the patients registered with them, but don't deliver things like the frailty service and other bits that they do out in Burton Wood. So we're helping the patients exercise choice, should we say, and providing an offer. That's different from previously, because there wasn't an offer to register with Warrington practices from Burton Wood. So hopefully that will help, and we're leaving that down to patient choice, because they do have the legal right to choose. However, if that is helpful and helps ameliorate some of the problems, it should do. There we go. And that's it. So that was the update. I think the rest is in the written report there, but it's early days yet, and I thought it was requested as a bit of an update. So that's as far as things are.
Oh, thanks, Andy. Jean, you want to come in?
Please, yeah. It's just about, I mean, this has been going on for as long as I can remember. I was a health visitor about 40 years ago, problems then, and it's resolved any. So if you get a patient coming out of Whiston, say, St Helens, and needs district nursing, it's an anomaly that who provides the district nursing? Can you tell me that, Andy?
So no, it should be really clear. If somebody's discharged from any hospital into Burton Wood, the district nursing service is provided by Bridgewater. It's ours because it's within the Warrington borough. So there shouldn't be any ambiguity. I know that dependent upon who people have called, because I think the issue that there isn't sort of historically have been when somebody's phoned the out of hours service to arrange district nursing, and it's gone through to the St Helens Rota or the St Helens On Call service, and they've tried to arrange through their usual channels a response for the resident, and that's not been appropriate. That's usually been in the individual operator error, because there are pathways so that if people live in Burton Wood, it should flag on their systems to contact our Bridgewater services so that they get the right service. But I know that's been a not a recurrent and not frequent problem, but it has been an issue in the past with the out of hours connection not quite working well and not working properly. But the pathways are clear, it's all there, but on occasion somebody just misses it and tries to go down a route that won't work, and that has caused delay, unfortunately.
Well, I mean, anecdotally, in the last year, I've certainly heard of a patient who came out of Whiston and needed end-of-life care and struggled to get end-of-life care, which is, you know, in my view, paramount. So, you know, do you feel that there is a solution to this long-standing problem, or because there must be other areas that have borders, you know, like we have borders with St Helens there.
There are. I think the bit that sort of amplifies the problem is Burton is a discrete community, but is part of Warrington, and unfortunately, for a whole host of historical reasons, have always been registered with 2 practices in St Helens. So when the commissioning and funding flows all aligned around primary care populations, that created the problem or exacerbated it. I think it was still a problem under PCTs, because I remember wrestling with that when I was PEC chair. So I think that the best option we've got is that if people choose to re-register with Warrington practices, that tidies up the problem, but it's a choice. And obviously people have relationships with their GPs, practices, often trusted going back years, generations sometimes. And so it's a big decision for somebody to make. But that's the only way we can do it, and at the moment we have opened that up to try and encourage that, and the challenge there is to deliver the right level of service and care, because the branch delivery has not been that great, and there's been limited access to primary care services within Burtonwood, so we're trying to increase the offer and see what happens with choice there, and there'll be a tipping point when it will work, but the councillors are working with the PCN to try and help, you know, win the hearts and minds and see what can be done.
Yeah, sure, that sounds like the solution, doesn't it? Okay, thanks for that.
It's not necessarily a commissioning problem, it's a registration problem, and I think we've got a different approach ongoing that we haven't tried before, so it's watch this space on that one, I think.
Keep my fingers crossed. Okay, thanks, Andy.
Okay, any more? If I can, Andy, I'd like to expand on the issue of district nurses and the offer for Warrington. It's come to my attention that the district nurse offer at Penketh and Culcheth has been taken out of commission since April, and if people need district nurse services, especially for redressing of wounds and such, and people who've been discharged from hospital, I'm being told that they have to contact Bath Street if they're on this side of the town, and that Bath Street has become a bit overrun, and people are being told now that because there's a waiting list in Bath Street, people from this neck of the woods are having to go to Widnes or even Lee to get their wounds dressed. It's not a very good state of affairs for as I say, our neck of the woods up at this end of Warrington, and I'm just have you got an answer to that, please?
So I think it's not the district nursing service that's gone, it was the dressing clinics. There were dressing clinics within the practices, and they were done as a bit of an outreach really from the main dressing clinics, and I think that's right, they were Culcheth and Penketh. Obviously with sort of constraints on the workforce, other infection control things, we had to centralise that into a more contained, controlled space, and that was sort of at the behest of Bridgewater really, because they were struggling to support the multiple points of delivery, and it was increasing some of the risks that they were carrying. So it's not necessarily a forever thing, but I understand it's been fairly long term, with it being since April. That's been running at Bath Street. And again, I think capacity issues have hit and across a lot of services, but Bridgewater have been hit particularly hard, I think, with some staffing issues. I think it might be something on that one that Sarah Quinn, I think she was on the phone with us, might be able to help with and make sure I'm not misleading you there from memory.
Hi, Andy. Yeah, it's Sarah here. I think the main reason that we can't use some of those locations is due to social distancing and infection prevention control reasons. So we're having to look at the facilities that are available, and some of our clinics, which are based in GP surgeries, are no longer accessible for that reason.
I see.
Thank you very much.
Yeah, it's just a case of a constituent of mine has been in touch to say, just been discharged from hospital and needs his dressings changed every day and can't get into Bath Street, and has been told to go to the Widnes Walking Centre. I'm not sure what the conclusion of that is. He's not got back to me yet, but that's a concern if we've got patients with serious wounds that need regular dressing changes, and that can't be affected in Warrington.
Yeah, I think Bridgewater do provide services at the walking centre as well, so it may be that's a close facility depending on where he lives, but Sarah, you wanted to come in on that one.
Yeah, I mean, I'm happy to pick up any individual situations and to look at that, but on the main it is just for our lack of availability into suitable estates and to be able to distance people. Okay,
we'll leave it there and hope we can resolve that one. If not, if this chap comes back to me, I'll obviously flag it up to yourselves. Thank you.
Yeah, that would be great. Thank you.
What up to now? Item 9, North West Boroughs merger with Merseycare. Is that Lorna?
Hello, hi. Yes, it's Lorna Pink here. I thought I was going to give an update on the provider, but I'll also talk about the acquisition. So we have had meetings with our Chief Executive and Joe Rafferty, Chief Executive of Merseycare. I've been doing staff engagement events. These have been really well attended, and it's an opportunity for a Q&A as well, so staff understand what's happening. The Trust have put into place a number of structures now to work jointly with Merseycare and to go through due diligence in preparation for the acquisition. They're all on track at the moment, so we've been asked for lots of information to provide from different services. That's been done from a corporate level at the moment, and then they'll move on to more engagement with the staff as we get nearer to a date for the acquisition. At the moment, we're still looking and expecting to be on track for the new financial year. However, we do recognise that all the information that's collected during due diligence needs to go to NHSI, and they will need some time as well to, consider that and to give us the go-ahead for the date. So that's it in terms of my update on Merseycare.
Well, thanks for that. Any questions, members?
Chair, Councillor Wheeler, are we still on target for is it the 1st of April next year?
We're anticipating that in terms of all the preparation that ourselves and Merseycare are doing. It will just depend on obviously the pressures on NHSE at the point at which they then need to do their scrutiny. So they need to have the information February, March time, and it's if they can then still work to those targets too, given the other things that are happening.
Yeah, thank you.
Chairman, is it
yes.
Mark?
Hey, Mark, yeah.
Yes, Laura, thank you for that. It's a fairly sort of basic question, really. I mean, I'm pleased with all this engagement you're doing with the staff, and that seems to be going well. But What, I mean, in terms of the residents of Warrington, what benefits do you think they might receive once this had all gone through, please?
It's a good question. I think that's something that we do need to engage more with the residents of Warrington. Obviously, this has been approved through the NHSE and NHSI systems, and that's some information I can get more of for you. I don't have that to hand right at the moment. I mean, the fact that we're a bigger organisation, that we'll have kind of some of the expertise from Merseycare and the expertise from North West Boroughs connected. One of the really lovely messages that's coming from Joe Rafferty is that Merseycare have gone through a number of acquisitions over the years. However, they've never acquired another good organisation from a CQC perspective. So they're welcoming ourselves joining Merseycare and kind of putting together the best of both trusts to hopefully have like the best experience for our service users then, and the wide range of services and expertise. But I can certainly get more information for you for next time if that would be helpful.
I think, yes, that would be useful. Thank you very much. Yes, please.
Okay.
Thanks for that. Anyone else? Okay, thanks, Lorna. Go to partner updates. I mean, some of this has been covered, so I'll just quickly run through if anyone else wants to jump in. First update from Bridgewater. Sarah, have you got anything else to say?
Yeah, I think what I'd like to highlight is really that obviously we're seeing increasing pressures into our community services, which your members have highlighted this evening in terms of challenges, in terms of service delivery. We're seeing both increasing staff sickness, both COVID and non-COVID related. We have our command and control structure in place, which is meeting 3 times a week, and we're currently assessing the position in relation to service delivery. All our services are currently operational. Some of them are working through business continuity, and we've also got plans in place to review what we would potentially need to step down should demands on services increase or that staffing be significantly further affected. We're supporting our hospital colleagues and social care colleagues in recognising the pressures in the system. We have our joint rapid response team with the council, and we're also working with our intermediate care facility at Padgate and just looking to maximise the use of this facility to support patients in the system. We have delivered all our urgent activity from the phase 1 of the COVID, and we're now reviewing all our waiting list again and clinically prioritising all our patients and looking at some of the patients who've been on the waiting list for a significant period of time. Infection prevention control teams are working closely across the system, and we have a community swabbing team who've been out and helped and supported with lots of different outbreaks within the Warrington system. We are delivering our flu campaign, and we're also preparing potentially for the arrival of a vaccine for COVID. So at the moment there's a lot of pressure within the trust and a lot of activity going on within the services.
Thanks for that. Members, any questions? No? Okay, thanks, Sarah. Move on to Health Watch Warrington. Lydia, are you there?
Yes, good evening, Chair. Lydia Thompson, Health Watch Warrington. We've submitted 2 reports for our update, which were circulated. And the first one was the Young People's Mental Health Report, and also the COVID-19 survey results report. I'm quite happy to answer any questions if anybody has any questions on those at all.
Okay. Members, any questions? No questions. I think they're quite comprehensive reports, Lydia, and thank you for that. No one else wants to come in. So thanks, Lydia, for that.
Brilliant, thank you. Thanks, Chair.
Northwest Boroughs, again, if there's anything to add, Lorna, I don't know.
Okay, so just in terms of service delivery, all our services are currently fully functional. We have the 24/7 telephone crisis line 2 that we introduced in April, but to support the infection prevention control, we introduced Attend Anywhere, an online platform in April, and month on month the activity for that's increasing. However, should it be clinically indicated or an individual require it, they can have a face-to-face appointment, obviously with all the suitable IPC in place. We do an evaluation of Attend Anywhere from a patient and a staff point of view, and we thank Health Watch for supporting us with that as well. Staffing situation, redeployment is not currently required, which we did need to do early in the pandemic to our urgent response services, but we monitor that daily with business continuity plans ready to implement if required. We're COVID testing our frontline staff who are asymptomatic. That's done every week. Our rate at the moment is 1.3 positive of asymptomatic staff, so it's lower than the average that's being told from public health at the moment. Our flu campaign is ongoing. I know there's a high target level for the end of November. I think it's 90%. So that's sort of having daily traction at the moment. In terms of our wards, we've got no patients at Hollands Park who are COVID positive currently, and we offer swabbing to our inpatients. In terms of our occupancy, since June and to the current time, we remain at over 100% occupancy. This is the national picture, unprecedented levels of admissions, particularly around 3 groups of people. So those who have been known in the community for a long time have suffered a relapse. Those with mental health problems which have been exacerbated through the use of drugs in particular. And then a group of people that have never previously been known to mental health services who are presenting in crisis. And it's becoming evident that this is related to the impact of the COVID-related social issues and social isolation, people losing jobs, losing family members, etc. The acuity therefore across our male and female wards is really high, and unusually we're having kind of the majority of patients now are detained under the Mental Health Act, which I think is sort of reflective of the acuity. And we're seeing some increasing demand for our dementia wards currently. We've got our trust assurance systems in place to manage the demand and review the use of the resource throughout the trust. And that's through daily staffing calls, daily bed flow management calls, daily sit rep calls, and daily operational delivery calls. So trying to work across the site and across the system. And we have a clinical ethical reference group that was introduced early on, and that's really to deal with thematic queries from clinical services. So you've got experts across corporate and clinical services sitting on that group, including our medical director. So visiting, for example, was one of the things that was taken to that. We've refreshed our business continuity plans and updated our quality impact assessments, and that will inform decision making if our staffing levels are severely impacted again, and we have to look at either redeployment or temporarily stopping some activity. So I was trying to be quick for the time. Are there any questions though?
Oh, thanks for
Chair.
that. Comprehensive. Yeah, yes, Judith.
Thanks, Chair. What's been the impact on the CAMS service?
Right, the activity for, well, the referrals to CAMS dropped off dramatically from April till approximately August, and that's starting to increase again now. Now, seasonally anyway, in October we often see a high number of referrals, and it's after children have got back to school, got settled in, and the honeymoon period's over. So we are starting to see that pick up. But as you'll know, in Warrington, there's been investment in the mental health school teams, in addition to the system working under the Thrive model, which is really suitable. Basically, people can self-refer to CAMS. There's duty practitioners available every day to speak to people, and we've got our 24/7 response team as well. Initially, the CAMS children, we thought would love the Attend Anywhere, and they didn't want to use it, so we carried on with face-to-face. But gradually, they're being shown that, and they're feeling more confident, and they're finding that's something that's suiting them better as well. Is there anything else in particular about CAMS you wanted to know?
No, I was just I'm surprised. Yeah, I mean, I could understand if it was increasing substantially now. Well, you know, it's COVID's it's affecting everybody, whether you've got mental health problems or not, you know. And I was speaking to somebody today whose daughter, you know, developed severe anxiety related to sort of CAMS, which progressed into an eating disorder. And, you know, there's all these, you know, complex things that are, you know, are just coming to the fore, aren't they? You know, and probably will be for a good few months to come.
absolutely. Yeah, all those social pressures are on them as well, aren't they? Yeah. Yes, I think it's about, I mean, the Thrive model that was introduced probably 3 years ago now, as you know, was co-designed across the system, and I think it just means that there's access to mental health support at lots of different levels. So, 24-hour online support. The crisis line is for children as well as adults, or for their families or carers. And then we've got school links work, and we've got the mental health support teams too. But obviously, we will keep looking after them.
Yeah, that's good to hear. Thank you.
Any more members? No. Well, thanks, Lorna. Thanks for that.
Oh, thank you.
Thank you. Bye for now. Moving on. Sarah's gone, I think. So, Amanda Amesbury, and Borough Council. Can we hear from yourself?
Yeah, I don't know if Kath Jones seems to say she's on hold from an adult perspective, so I don't know if Kath's there to address the adult bits. No? Okay, so I know from an adult perspective, Kath's been working hard with the hospital around discharge of patients and making sure that we've got sufficient capacity in the care homes for patients who require ongoing care. I don't think that's been easy, but there's been lots of sit-rep meetings involving colleagues from the hospital in planning for that. Kath, we've had significant impact on our services from our response to COVID, both across children's and adults, but more impact on adults with lots of staff self-isolating, off with COVID themselves. So, and also with the responses to the pandemic generally, which means that Kath has been looking at the Care Act easements, which she's allowed to do. It's regulatory allowed as a response to COVID, but Kath's looking at what we need to do in order to increase capacity around our COVID response and what that will mean for the rest of our responses in adult social care. There's support through Eleanor Blackburn to supporting the clinically vulnerable, what were previously shielded people. So there's a package of support in place there. In terms of children's, not as impacted on as other areas. Obviously we know about the schools, and we've had updates about that before in Tara's updates, but also just to inform members, there's been a bit of a glitch today in that 74,000 letters have been sent out nationally to children and their parents, telling them that they need to shield, and there wasn't any review of those 74,000 children. And actually locally, most health providers and local authorities felt that could have been significantly reduced. They've just gone out randomly to 74,000 people. So we're just unpicking that locally. Kelly Williams is working with the CCG and local GPs to offer assurances to any child and family who've got that letter locally, and to be really clear who does need to shield and who doesn't, because from our perspective, if a child can be in school, they should be in school because of the wider societal implications on them and the implication on their ongoing education. That would be it, I think, really, unless Kath's not on hold anymore and can help out with the adult.
Yes, she wants to come in. Kath, are you there?
I am. Yes, can you hear me?
Yes, we can.
Yes, so from an adult care perspective, it is quite a challenging situation. I think what's actually happened in wave one, which hit the NHS first, in terms of the demands on social care, that really came after the impact on the NHS, a bit like a tsunami. Because in the first wave, a lot of families and carers were furloughed and were able to look after their loved ones. Obviously, that went on for several months and put a tremendous strain on carers and families. And in the more recent months, people have gone back to work, and the stress has really begun to show on carers. This is partly a result of the fact that we also had to close down respite and day services because of the social distancing and infection control requirements. So what's happened in the last 3 months is that there's been significantly more demand. We're actually on higher levels of referrals now and packages of care than we were pre-COVID, as the strain is felt by families and carers, in part as well because although we had started to set back up our services, our respite and day services, we've had to do that at much reduced numbers due to the fact that we've had to do, delivered services outside, socially distanced. So it's been quite challenging for our providers to set up care. Having said all of that, some of our parts of our sector have remained extremely solid. So in terms of our domiciliary care providers, we're now delivering over 9,000 hours a week. Infection rates, considering the situation that we're in, are quite low. We're managing to deliver the care. We have very few packages of care waiting. We're managing to support the hospital in maintaining flow. So that's really encouraging. Similarly, in our supported living arrangements for learning disability and mental health, the services remain stable and we're able to cover the care needs there. With regard to care homes, we have seen, as Tara alluded to, we have seen infection outbreaks in care homes. I think we are on about 9 settings which are currently closed. Generally, the outbreaks are of very low numbers, usually 2 or 3 staff/residents, and those generally haven't increased. We are working at least twice a week communicating with our providers so that we can give them all the up-to-date guidance. We can communicate with them in terms of we link in with our infection control colleagues to ensure that they are well supported. Money has gone to all of our providers to support them, both in terms of infection control, managing the environment, purchasing PPE, all the aspects which additional staff support to ensure that they are able to deliver a sustainable and a safe service. Having said that, understandably, our care home sector are very nervous about the infection in care homes, very understandably, given what happened in the first wave. So there are some challenges with our care homes not accepting patients from hospital who are COVID positive, which is placing more of a strain on the system. I think it is understandable, but it is creating some challenges in terms of capacity. There are plenty of our residential and nursing homes have capacity and have vacant beds, but are understandably unwilling to admit to those if someone is COVID positive, because we need to do that in a controlled way and in an isolated way. So there is we have a mutual cross-border arrangement for a designated facility to accept people who are COVID positive from hospital, and we're working to see if we can develop that further. So the system, what I would say is that the system has worked extremely well together. We have virtually daily calls with our hospital and CCG colleagues to make sure that wherever there are any blockages in terms of flow and patient support, that we're able to deliver that. We've also been working really hard with our care homes to ensure that families are supported around the issue of care home visiting. This has proved to be a very sensitive area, and this is why we've come up with a risk assessment that we are supporting our providers with, because every situation is different in terms of the relatives, people in the care homes and their relatives in terms of their situation. So we are encouraging and supporting our providers wherever we can to encourage a safe and proportionate approach to contact with their relatives, because we recognise it is so important for people's health and well-being. So we're doing that very carefully and with the support of our infection control colleagues as well.
Thanks for that. Any questions, members?
It's Lucy Gardner from the hospital. I just had a quick question around the 74,000 letters, if that's okay, in relation to shielding. Do you have any idea yet how many of those might relate to children who live in Warrington?
No, but Kelly Williams is in touch with the relevant people from your end, so that information will have been passed over.
That's great, thank you. I guess I'm just thinking about, you know, the potential risk in terms of staff who might then have to look after shielding children. Yeah, thank you.
So those reassuring messages have been going out quite quickly via Paula's teams and early help colleagues and the schools, importantly, themselves.
Thank you so much.
Okay, anyone else? Any questions? No. Well, thanks, Kath, and thanks, Amanda. She's gone. We move on to anything from Warrington CCG. Andy, again, I just wondered if there's any news on the mergers. Andy.
So nothing really to update from last time. We've still got the ongoing conversation with Cheshire and Mersey Health and Care Partnership. As you know, there was the letters that went round around a single CCG per ICS. The latest sort of development is we're looking at some form of joint committee to help with collective decision making at a Cheshire and Mersey level by April next year. And the longer date is the April 2022, but there's nothing formal and decided about that. And we've been pushing to say, look, we need to get the place stuff sorted before we start thinking about that. And that's getting a lot of traction. So we'll hopefully have more to say on what we do about the integrated commissioning offer at place as we go through that process. Obviously, it's a bit it's a bit unusual trying to do this one while we're all socially distanced as well. So having Skype calls and other things and getting bits of the story. But yeah, more than happy to engage in any conversations, but it's fairly slow at the moment.
I see. Members, any questions for yourselves? No.
Could I just update on another couple of bits? Sorry.
Sure, Andy. Yeah.
Yeah, just to note, we've had some increased cases in primary care of COVID. So within the primary care teams, they've enacted business continuity measures, reviewed IPC processes, and some practices have been fogged as well, just as a precaution, even though we didn't have any in-practice transmission to note. About 7 practices affected so far. Probably the most significantly impacted was culture early on, but we resolved that over last weekend. So I think it shows that there's an increase in prevalence in the community, and that's having an impact on services that way. And then, yeah, I think that's probably the most significant bit to go through.
Thanks, Andy.
Always.
Members, any other questions? No. Okay, we've got the final one again. It's Warrington Hospital. Lucy, have you anything to add? Any updates?
Nothing significant to add over and above the earlier update, but happy if there's anything specific that people would like to ask questions on, of course.
Okay, thank you very much. Move on to our work programme.
Sorry, Tony, I was just unmuting myself.
Oh, sorry.
Ian Marks.
Hi, Ian, go ahead.
Apologies for that. Yes, I think it's been a couple of months since NHS 111 first started with our pilot. I just wondered how it was going, and how much it was being used, and whether it's working successfully.
So it is working successfully. In terms of how well it's being used, I've just got our dashboard here. Bear with me 1 second, and I will see if I'm able to tell you that.
Should I help out? I got some figures today.
Thanks, Andy. That'll be fab.
So it's been ranging between about 5 and 15 people coming through per day on the service. It looks like over that. So that's within the forecast that we had, but less than the 20% heralded that we were aiming for. And obviously that's because it's not formally launched, but a lot of the systems and processes are being tested, you know, like the telephone, the electronic handover, the other services, and developing a bit of an array of services behind, like the gynae assessment unit, the frailty assessment unit, paediatric assessment, all that as other routes and other avenues following CAS. So yeah, it seems to be going well. And I bet you found your dashboard now, Lucy, haven't you?
Yes, thanks, Andy. You were much quicker than my dashboard, though.
I've just had to talk to it today.
Okay, thanks for that. Just a quick one from me for maybe everyone. We had that major incident with the Northwest Ambulance Service. Any idea what the impact was on Warrington for any of you? General question.
From a hospital perspective, there wasn't a significant impact.
There you go. I'll get the actual incident. I think was triggered in GM because they had problems there, but obviously it affected across the northwest. So they had ambulances stacked in Greater Manchester, which was why we were depleted locally. But they'd resolved it by 8 PM, I think, later that evening.
Okay, thanks for that. Right, any other members, any other questions? No, okay. Well, the work programme is significant and encompasses all our work. Excuse me. So we just carry on with that. And I think that concludes the meeting. Any other questions about the work programme, members?
No.
Chair, just a quick point. Do we have Julie Haywood on the line at all?
Julie Haywood. I can't see anyone.
No, sorry. I was just expecting an update on an update from Julie, but she doesn't appear to be on the call at the moment. So. Right. There's one right at the bottom, which is a Warrington number that's muted. I don't know who that is. 753051. No. 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 Okay.
Chair,
well, thank you for attendance. Sorry.
Chair, sorry, it's Andy. Just as a thought, with the question we had earlier about the prescriptions in schools and ADHD, there's an item on for January around the Thrive model. Would it be worth a bit of an interim update on the neurodevelopmental pathways? And obviously I can ask some questions about what we're doing with regard to medications in schools as well.
Yeah.
Would that be helpful?
Amanda, you still there?
Sorry, yes I am. I'm trying to get off mute. Yeah, that'll be absolutely fine.
Okay then. Well,
we'll do a double act.
Yeah, do a double act. Well, thanks, Amanda. My best wishes to Mike, and tell him someday we'll share that curry. There you go.
Okay.
Okay, call the meeting to an end, and thanks for your attendance. Bye for now.
Bye. Thank you.
Thanks. Thank you, Chair. Thanks.
Bye. Bye.